All right, so we are going to be doing a wrist arthroscopy here, which is a minimally invasive surgery where we insert a little fiber optic camera which illuminates a joint. We all know about this in knees. You read about it in the sports pages, but nobody ever talks about it in the upper limb, let alone the wrist. Wrist pain is something that can be due to many different causes, and the truth is, let's face it, when you go to your general doctor or your ER or your urgent care, they really don't understand the wrist, just like I don't understand your eyes. And not only do you need to see an orthopedist, but you really need to see a hand and wrist specialist. So this is a highly competitive volleyball player who flew in for this, and she's been having over a year of wrist pain on what we call the ulnar side, the pinky side of the wrist. She has pain with any rotation, like turning a doorknob, but certainly she has pain with bumping, right, where you're doing the ulnar deviation, and she has pain there, which we think, based upon my exam, is probably a cartilage injury on the wrist, which we call the TFCC, very similar to meniscus. You know about it all, the soccer players with the crazy haircuts. We all know about knees because of soccer, but we don't know about wrists because it's not talked about. So hopefully we'll learn something today. Here we go. Okay, how are you?
Good. Hi.
Okay. So Denise is a surgical tech who will be handling the instruments. This patient is not general anesthesia. There's no need for that in most of what we do. She is sedated. You might hear her snoring a little bit. But she is blocked, meaning that the area that we're going to be doing surgery on is completely numb. So our goal here is first to find out exactly what's wrong, because even though everyone always thinks that MRI is the last word in the wrist, the MRI is only a little bit helpful, but it's not diagnostic. So in other words, it may give me an idea of what's going on, but until I really put the scope in, we don't have a clear diagnosis. And we will in the next 5 minutes. And then at that point, not only do we diagnose it, but we fix the problem. Okay, so the wrist is in an apparatus that provides traction, means it opens up the joint. I just did a shoulder arthroscopy about 30 minutes ago in this same room, and we do something similar. Now she's applying the traction. And I'm going to actually squeeze out the blood so that even though this is not a bloody procedure, this way we don't have a lot of blood potentially in the joint. Turn it up, please.
Time out.
Time out.
Yep.
This is Dina.
Go ahead, just read the
Left wrist, arthroscopic, triangular fibrocartilage complex debridement, synovectomy with limited open repair and thermal shrinkage.
Hold on. Mommy, can you repeat this one, please?
It's not going up.
So
Hold on, is it blue? Yeah, I know it's the wrong one. Oh, the blue, yeah, the switch. Okay.
all right.
1041.
So here we go. So now you'll see that the veins are more collapsed, and so now this is, hopefully this doesn't gross anybody out, but we're not going to make incision here. We're just going to make really a little hole. Here we're going to fill up the joint. So what that does is it distends the joint. So this is just called a portal. It's not even really an incision. So now I'm in the joint, and I see the fluid come out now. Now I'm going to go in. This is a sheath, and the camera is going to go inside the sheath. Incidentally, I'm honored, our center's honored. We have a lot of visitors always from around the world, a lot of colleagues. And today we have Dr. Armin Hyman from Estonia, the country of Estonia, the capital city, Tallinn. So Dr. Hyman is also an expert in wrist arthroscopy, because we are both charter members of something called the International Society for Sport Traumatology of the Hand. It basically means that we are not only hand surgeons, but we have a particular interest in athletes, such as this young lady and in wrist arthroscopy in particular. We're both members of the European Wrist Arthroscopy Society. Okay. Kate Samuels is our PA, so the lights off. So here we're inside the wrist joint that's focused. So we are inside. We can get that light off too, please. No, the ceiling light. Yeah, get that off. Okay, so we're inside the joint. You can see it's transilluminated. We're looking now at the scaphoid, which is the most commonly fractured bone in the wrist, the radius, and then these are the important ligaments. All right, and I'm seeing some inflammation there. That red is inflammation. This young lady has been having pain, so no surprise there. And now we're looking at, and there it is. There's her tear. I can see it already. So already we diagnosed the problem. And it's not that it's nothing exceptional. It's simply that this is what we do every day. And you have wrist pain, you want to see a wrist specialist. You have knee pain, you want to see a knee specialist. So what we're doing now is creating another portal so I can, oh, I got a little vein there. It's funny. Something that never happens. It happens now, but it's not a big deal. So.
Next patient ready for pre-op.
So what we do is we dilate this portal. So you might want to come on my right side because now I'm just opening it up a little so you can get this shaver. The shaver is a machine that actually does the surgery for me. So the camera sees it, visualizes, there's a little bit of a tight joint, which is not surprising. Young healthy patient. The older patients that we do this on, you get in very easily. Yeah, do they have a bigger clamp, please? Need a holder, please. Tight joint.
Please copy now. Please copy now.
Okay, there we go. Okay, so now we see on the monitor, you see so now you see this circulates and it's going to, now we're going to aspirate, meaning that we're going to suction, and this gives us the opportunity to remove the tissue. So this is the inflammatory tissue that we're seeing here, called synovitis. As soon as I clean this up a little so we can see better, we're going to look at what the problem is. So this is much more diagnostic than, so now I'm going to take a picture of that so I can show the patient and the family. So you see when I apply suction, it suctions it up. So I need, please, I need a radio frequency shrinkage probe, please. So this is actually great news, and in fact she doesn't have a tear on the outside, which we would have to repair with suture, and she'd have to be in a cast for about 5 weeks. In this case she doesn't. So this is great news. Now this is not a usual tear that we see in somebody younger. This has a little bit to do with her anatomy. A little bit technical to go into, but bottom line is everyone's different, and she has some anatomy that predisposes her to this. So the TFCC stands for the Triangular Fibrocartilage Complex. try to say that after a couple tequila shots. It's basically similar to the meniscus of the knee. So if you didn't see this tear, you would think this is the same as the joint surface, which is cartilage, but it's not. This is not cartilage. I mean, it's a meniscal type cartilage. In this case, it's a fibrocartilage. And what's hurting her is the fact that you can see every time I apply suction, you see it comes up. So when this patient's moving her wrist or doing sports or putting vigorous, this thing's moving and causing this kind of this, what we see all this reddish stuff, this inflammation called synovitis. And that's what the brain interprets as pain. Right? So our goal here is to solve her pain. And we're going to be able to do that. So now you see the tear a little bit better. Let's probe it, please. Now I can't be sure that she doesn't have a ligament tear as well, and we're going to look in a different part of her wrist. But there is what we call a central to really radial. This is more of a radial sided. And my good friend Andy Palmer from upstate New York actually came up with the classification. So this would be a Palmer type 1D, as in David, 1D tear. So, not to bore you with specifics, but all of these things obviously have dozens and hundreds of scientific articles, and that's how we talk to each other. Now, this is a probe where you're going to see I'm going to tighten the tissue. You see it there? So you can't be too aggressive with it because it can cause some secondary issues with the tissue, but as long as you're judicious about it, this is extremely helpful. This will tighten it up. So what do you think, Dr. Hyman? Palmer type 1D tear, just a lot of people, right, used to try to do repairs of this. Try to actually reattach it to the bone.
It's not necessary.
It's not necessary, exactly. And the main reason is because it's not vascular. This is tissue that if you try to repair it, it won't heal because it doesn't have any blood supply. And I remember 15, 20 years ago, I had a number of cases I did, and they actually did okay. But it was honestly more work and trouble than it just was fruitless. Just doing this, see now it's a stable. But here, if the tear was here, then it would heal because you can see it's the tissue has a different quality. But we don't need to do that in this case. We're just tightening it up. So this is great use for her and in her sports career. I mean, we should have her playing volleyball within 3 to 4 weeks. Okay? So now what I am going to see is I want to look, while I'm here, I'm going to treat a little bit of this synovitis here. Not crucial, but since we're here. Okay? And what we're going to do now is look in a different part of her wrist. This is the ridge between, you see this a lot in athletes for some reason. It's sort of, in the knee they call this plica, but it's just a little fold of tissue, and I just tighten it up a little bit. But I'm not sure. And then this is actually her main, one of the main ligaments of the wrist, the scapholuna. You see this is soft, that's a ligament. And that's the kind of tear that you get when you fall, and then these are patients who've had wrist pain 4 or 5 months and nobody's diagnosed it. Why? They haven't seen a wrist specialist. But we would know by our exam that they may have a tear of that ligament. And in fact, I'm going to take that picture so I can show her that this important ligament of her wrist is perfect. But now we're going to make sure, well, she's got a tight wrist, I'll tell you. It's unusual. So now I'm going to go into a different part of her wrist. So I'm injecting fluid, but it doesn't come out the other portals or holes. So that means that it's very unlikely that she has a significant wrist ligament injury. Thank you, Denise. The nice thing about operating in a center like this is that everybody knows. When I go to the hospital, honestly, it's a lot more dialogue than is necessary. Here, since we work together, you notice I don't even have to ask for things because everybody knows it's a team approach. kind of like cardiac surgery when it's the same team. A little more important there because if not, the patient can die. Okay. Now I'm seeing something here that is a little concerning to me. You think there's a tear?
I'm not sure.
Let's see. Okay, so this is the scapholunate interval, so when I press on the bone, there's a little bit of motion. You can see that. But there's no step off and there's no tear. So this bone above is called the capitate. This is called the lunate. Okay, it looks like a moon. That's why it's called the lunate, la luna. We're in Miami, so we all speak Spanish. This is the scaphoid, the proximal bulb. But now, when I look over here, you see the redness? That tells me that there's inflammation going on there, and I am now very concerned. We need a 4-5 wire getting ready.
Don't open it yet, just have it available. Yeah, we have it in there.
Okay, so now I'm going to make another portal. This time I'll try not to get that little vein to annoy me. There we go. You see the fluid shooting out. You can see we're doing surgery with little holes. We're not even going to put a stitch in these. There'll be no scar on her at all. Of course, that's not what our concern is. The point is just that it's not very painful and it doesn't cause any problems of scarring and stiffness. Now what I'm going to do is clean up all this frayed tissue, because I can't even see the pathology of the problem, right? I'd love to hear comments from, I have colleagues, friends from around the world who do a lot of wrist arthroscopy, so they're probably having a good laugh right now. Look at Alejandro teaching. But I think it's very important. You know, I was speaking with Dr. Hyman from Estonia, who I had the pleasure of visiting a couple years ago. And at conferences of doctors, we always speak to each other about things, right? But I think it's our patients that also need to know, because they're the ones who are going to benefit. So there needs to be a lot more patient education, and that's something I've always been interested in. So hopefully this will help somebody somewhere around the world who's got wrist pain for 6 months, and they keep being told maybe by their family doctor that they have a wrist sprain, and after 6 months, if you're still having pain, there's something wrong, and you saw the tear. Now what I'm worried about here is a ligament tear, which is different, a little more significant. Okay, because I see a step off between these bones, and I'm going to show you now. So now I'm finally able to see better. You can see the top of that bone there. So the cartilage is the white stuff, and the yellowish stuff is actually the bone, the spongy bone of the triquetrum. This is called the triquetral bone. One of the 8 wrist or carpal bones of the wrist. Now, what I don't like about it is I don't like the fact that there's a step off, and I don't like the fact that there's so much motion. There should be a little more motion in that interval, but that motion translates to wrist pain when this young lady tries to. Yep, so I'm able to put that probe. A good friend of mine named Will Geisler from Mississippi came up with the classification. Now this would be a Geisler 2 or 3, but I don't like it, and I'm not going to accept it because she's been having wrist pain and she has a high pain tolerance. You see, the bone is stepped off, but when I push it down, this is where it should be. And that's because the ligament that goes between them, particularly here, is frayed and torn. So, Armin, I'm going to debride this and I'm going to pin it. Right there, see? So that's a little bit stretched out. These are 4 bones. Right? The capitate up here, the hamate bone, triquetrum, and the lunate.
Stitching as well? Where are the frequency?
She what? Yeah, she has like a shuck test. Yeah.
Next patient ready for pre-op.
So I'm going to debride this. What this does is I'm hoping that, well, not hoping, I mean, what happens anywhere you create a little bit of bleeding, you get formation of scar, and that will stabilize the new ligament that will form. So that's what I'm doing here. You can see the step up, there's a little step in the bone right there. Right there, thank you, Kate. Okay, while we bring the machine in to do the pinning, because we do this under a live x-ray. I think we can take any questions, if there's any questions.
Nope.
Not yet, I'm surprised. Early in the morning, everyone's working. Okay. So I created right there that raw bone that's going to bleed when the tourniquet's released, and that's going to create a new ligament. We'll do a little shrinkage of this tissue. So now we can see the wrist illuminates more. Why? Because I've removed a lot of the inflammatory tissue. Before it was a little bit darker. Now it's very light, which is good. Okay, so here's the radial frequency. I'm going to tell you this tissue's a little redundancy. Just how that tissue tightens up. So this is a technology that was first used in knees, and we use it a lot in the shoulder. And well, I've been using it in the wrist for 20 years now. Okay. No, I don't think so. I think we're ready. We're ready to do the pinning. So all we're going to do now is eliminate the sort of this motion that you see here by putting 2 pins across that are going to be cut underneath the skin. You won't even see them. And in about 7 weeks, here in the OR, we'll remove them. And then the patient will start the therapy. Okay, there's the scapulina. It looks perfect. You notice the difference between this interval and this interval. That step off right there. Okay. Good, that annoying little bleeding stop, Kate. All right, we need the lights on. So, actually, this is interesting because you're going to be able to see the entire procedure. And part of the reason, honestly, is that, hopefully you're not too bored, is that we do it quickly. Why do we do it quickly? Because I've probably done close to 1,000 of these. And so that's very important, I think, when you see the right specialist, is that they've done a lot of them, because it ends up being very, you know, like a symphony. So it's only been 19 minutes. So now we're going to take a pin. So this is the carpentry work of orthopedics, you see. So that spins, and we're going to drive that pin between the interval of those bones to let the new ligament form. You want to come over here because you can see the, so okay, if you can flip it 180. Right?
Balcony Park 4, Balcony Park 4.
You can so we're going to remove the loam, okay?
Good there or more?
Yeah, that looks good.
Part 4. Milky Part 4.
Take a look and see what's going. Illuminate, perfect. Cutter, please. You look at this, see the bones now move together because I put a pin between them. Now we're going to put a second one for a rotation. Yeah. So now we're going to cut that first pin under the skin. It doesn't bother the patient. She's going to be in a cast anyway. It doesn't bother her. And I already know where I want to put the second pin based upon my two views. Good. So both pins are now across the lunate and triquetrum. So they're immobilizing that. It's, pins. You can see the pins here. Okay, so the pin's right there, and then we're cutting it. So this patient's really going to have there'll be no stitches, but we did all the work. You saw it on the big monitor. Now we're going to take a picture so I can basically explain to the patient and the family what we did, so they understand what we found. Print. Okay, you can come out. Yeah.
Please, here, please.
That's come over here. So we don't even use stitches here. This way there'll be no scar. So we just put a little sticky material. People call these, we call them butterfly bandages, right? I never knew what that was when I was in medical school. Like a lot of layman terms. But these are called steri strips. Get down, we have that little vein there.
One.
So that's,
Uno o dos? One. Uno.
you notice there's no stitches. The patient will have basically no scars. See who's the boss here. You tourniquet down. So now we release the tourniquet, the blood rushes back into the hand, and the healing starts.
11 and 6.
The scissors, release her.
Yeah.
There we go. So this patient immediately, in fact, she's still pretty sedated, right?
Yes.
In a few minutes, just you let her, don't wake up. She's snoring a little bit. That's good. That's what I want to be doing, right? In fact, there's probably a lot of viewers snoring right now, but I won't take that personally. So we got to get Jimmy Kimmel in. Actually, Jimmy Kimmel, isn't he the one who had the?
The fingers.
Yeah. So Jimmy Kimmel had an injury that actually put hand surgery kind of on the map. A colleague of mine.
Was it Fallon? I think.
Oh, it was Jimmy Fallon.
Sorry.
I think they're the same people, honestly.
Sure.
Aren't they the same people?
No,
You ever seen them in the same room together? Jimmy Kimmel, Jimmy Fallon?
Jimmy Fallon is much funnier.
Is he? Okay. We have an opinion here from anesthesia. Their opinion matters a lot. So yeah, Jimmy Fallon fell in his kitchen, and on the way down, caught his finger on some sharp object, and it basically tore. It caught his ring. It's called a ring avulsion injury. And friend of mine from Columbia Presbyterian, very good microsurgeon, basically reattached it, and he's done very well. But other than that, you never hear about hand surgery in the media, so that's why these things are so important. So this is plaster. This is where orthopedists get to play, right? We like to get all messy. The internists don't like us. Okay. So this will mold to her wrist. It'll dry, and then next week we'll substitute this for a light cast. See how kind of reddish her hand is? That's because we had squeezed the blood out, but now the blood has rushed back into her hand. So we will keep her face covered, just but in a few moments you will see that she can move her fingers. So she'll have a little bit of pain tonight, nothing terrible. You just saw it in some holes, but team approach, right? Okay. Did you wait? Not yet.
Yep.
Can you open your hand for us?
Nina,
Good.
your surgery's all done, honey. You just had surgery.
Make a
There you
fist
go.
for me, okay? Close your hand all the way.
Make a fist. Still a
Make
little
a
bit.
fist.
Yeah, she's just
Do this. See my hand? Go like that. That's it. Go like that.
Open your hand now.
Open. Nina,
He's groggy. I gotta have some of that.
open your hand.
So,
Open.
I don't know if there's any questions, but you got to see, usual, sure?
You did really have surgery.
She's asking if she really had surgery.
Patient's asking, did she really have surgery? The answer actually is no, because I don't tell patients that this is surgery. I say it's a procedure. Big difference, right? Patients hear the word surgery. Surgery is like what we were supposed to do later today, is put in an elbow, a new metal titanium elbow in somebody. The case got postponed because the cardiologist still looking. It's an older patient, but that's surgery. These wrist arthroscopies are procedures, so there's no reason to be afraid of this. To me, what you should be fearful of is the fact that you've had wrist pain for a year and nothing was done, and now the technology and the know-how and techniques that have been advanced and promoted with groups such as the European Wrist Arthroscopy Society, of which we have an important member with us today. That is what has advanced medicine, and that is what I hope doesn't get lost in all this ACA and Obamacare stuff, is that really the way you keep healthcare costs low is to get expertise early on. Okay? Many of these patients come and see me after they've seen 4 doctors. That's where it's expensive. If you can route people to the right person earlier, which is what we're trying to do with our Ortho Now concept, then we really save money. And hopefully all the money that we save actually allows us to give medical care to the people who are less fortunate and have more of a challenge to pay for it. And that's what I'd like to see, and that's what we're working on. So I hope you learned something. These are the pictures I'll show the family. Here's the cartilage TFCC tear. Okay, and then here is the tear. There's a tear in the ligament that allows these 2 bones to move. And now we put the pins across, and the problem will be solved. She should be playing volleyball back in between 3 and 4 months from now. Thanks.